You guys had fun so far? Yeah? Hey, I think it's been a pretty good event. I mean, I'm a little bit biased, but I think it's been pretty good. Hey, when we started SMS 15 years ago, actually we started doing conferences closer to 20 years ago. When I first got out of respiratory school, I went and started working with the TSRC and ran their programs committee for a little while, and saw that this was kind of fun, and I like getting people together. I'm a community guy, so I just like getting everybody together and seeing all of our colleagues and seeing all the vendors, and so I love going to shows. I don't know about you guys, but it's one of my favorite things to do. If I sit in the office too much, me and Kim were just talking about this, like if I sit in the office too long, then I just start, I don't know, I just start getting in this place where I'm like, I don't like my job anymore. I can't sit in the office all the time, right? I'm just a guy that's got to be out talking to people, and so I'm the guy that Ken talked about yesterday that's up at everybody else's desk all day, like, where are we going to eat? What are we doing today? Like, I'm definitely that guy, right? And so I'm a community guy. So we started doing this, and we started doing conferences in Nashville and then Kentucky, and then the SMS started 15 years ago, so actually before Encore. So this was a company that we had before Encore, and we kind of rolled it into Encore, but it was a vision that we had just to bring the state together. And this year we had people registered from, what was it, 26 states? 26 states. So there's 100 plus people watching online right now. What's the number online? Okay, almost 100. 98 online. So we had several people tune in from all over the country. So it's pretty cool to see what's happened, right? And we thought about getting rid of virtual just because we like everybody to come and be live, but it's been such a powerful thing to have virtual. And actually last year we had a couple that said that they brought their child who was on a ventilator, and one of them would come to the conference and one would stay in the room, and they would take turns going back and forth. And so I was like, well, I can't cancel virtual now, I guess. But it's cool to have virtual. It's cool to have that option. But I just love everybody coming in person and spending time with the vendors and getting to see everybody, right? So we're going to talk about AI-powered respiratory care. And so I just want to do a little, that way again, a little disclaimer. I move a lot, so I'm going to stay away from the edges. I'm not working here. Hang on. There we go. Little disclaimer, we're going to see this presentation together for the first time because I had AI write it for me, and so we're just going to go through this together, right? I'm just joking. So respiratory therapists have always been known as the MacGyvers of healthcare, right? Anybody heard that? Do they still say that these days? I mean, back in my day, it was like we had to, when I started, respiratory therapists were putting all this stuff together. I remember in school thinking, there ain't no way I'm going to remember how to do all this stuff, right? But it's really evolved over the years, and the MacGyver piece has gone from figuring out how to piece everything together to figuring out how to solve problems. But it's pretty awesome to think that we're the MacGyvers of healthcare, and some people in here may be thinking, who the heck is MacGyver? Maybe. But I also came up in a family of MacGyvers, and my father, respiratory therapist, my uncle, respiratory therapist, and you know they've been in respiratory 51 years now. He celebrated 50 years last year, which is a pretty big accomplishment, right? 50 years in respiratory. And so, but the thing that I saw them growing up was, so in my book, if you've heard me talk before, you've probably heard me say this, but it was like nursing, physicians, astronauts, and then respiratory therapists. And so respiratory therapists were my heroes. And so when I got out of respiratory school, like I was going to go change the world, right? Like I had this plan, and I was going to do whatever it took to change the world. I worked for Colleen, right? She knows, like I was trolling the hospital. Somebody needed intubated, I was the first one there, right? Yeah, she told me to stop, but I was going to change the world. And so I had this expectation of respiratory therapists, and I still have that same expectation. That we should have such a passion that we should be changing the world wherever we go. We should be world changers in every room that we walk into. And see, the challenge is oftentimes we get apathetic and we get to the place where we get tired of our jobs and we go through the normal routine. And so I just want to remind us today of the reason that you do what you do. The reason, what is your why? And Ken talked about, so he did such an awesome job. Wasn't he good? He was an amazing speaker. But he did such an awesome job just kind of getting us excited about it. That's why we have him first, or we have the keynote first, because it's really about changing our mindset, right? Because it's so easy to just be in the daily grind and do what we do every day and forget about how many patients' lives we touch. and what difference we could make just with a smile, right? I learned early on in my career that it wasn't about how much I knew, it was about how much I cared that patients knew about, right? Because they didn't know how smart I was, they didn't know what I made on my tests, they didn't know how good I was in clinicals, but they knew how much I cared, and the amount that I cared is what could make a difference in their lives. And oftentimes we forget that because we just are stuck in the normal routine, right? So I challenge us to get back to that place, because I bet most of you didn't get into respiratory for the money, right? We got into it because we wanted to make a difference. We wanted to be MacGyvers. And my dad, he used to have a MacGyver haircut too. Huh? You could bring that, he could bring that back now, right? Like, this is back in style, Dad. You could do this again. So let's talk about AI. Artificial intelligence. When you hear that, like, part of this room is probably terrified by it, part of this room is probably excited about it, and part of this room doesn't really care, right? Would you guys agree with that? A lot of us are terrified by it, but I would say that if we're going to be the MacGyvers of healthcare, we probably should embrace this, because this is the future. AI is involved in everything that you do today already. I mean, it's came on the scene in such a way that it's already involved in most programs, your banking apps, any app that you use, any technology that you use, Facebook. I mean, all those things are using AI to a really big scale. A lot of money is going into AI right now. And it's evolved so much in the last couple of years. And so whether it scares you or not, it's in every part of your life, unless you get rid of your phone and you go back to a pager or something like that, then you're probably going to be using AI for the rest of your life. And it's going to evolve so much. I mean, Elon Musk is coming out with a robot that you can buy for $40,000 that you can train to clean your house and paint the house and do all those things. I mean, I'm really excited about it. I want one. But, I mean, think about it. All the construction you do over 10 years, you can just buy a robot, teach it how to do it. It could do it for you, right? And that sounds crazy. Could you imagine 20 years ago us talking about robots? But here we are. And so AI is the future, but it's also what's happening now. So what is AI? It's the theory and development of computer systems able to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision making, and translation between languages. So that's the definition. But here's what we think about. We think about AI, right? This is what I think about. When I first started thinking about AI, the Terminator, like, is it going to take over the world? I mean, the robots, and now iRobot, you guys remember that movie with Will Smith? Now we got the robots. I wonder if they're going to look like this. So hopefully that's not predictive of what our future actually looks like. But if you watched the 60-minute piece about a year ago, it was one of the founders of AI that talked about how do we keep AI from taking over the world, and how do we keep it from endangering us at some point. So there are some real threats with AI, and you know, the more we use it for good, people can use it for bad as well. So AI is really interesting, and I don't know if you keep up with it much, but it really comes from large language models is probably the thing you've seen the most. How many people in this room use ChatGPT or any kind of AI? Yeah? I use it all day, every day. It's like my best friend now. When I am stuck in the office, I just talk to it, talks back to me. You know, it's actually pretty cool. It's got its own little personality. It picks up your slang. It understands more things about you. It starts to learn about you. If you use ChatGPT, then the more stuff you put in, it says memory updated. And the other day I got on it and I just said, what do you know about me? And it gave me like my whole life story and who my kids were, and it told me what I did for a living, all my jobs. And so it's pretty cool, because the more it picks up about you, the more it understands about you. I feed it presentations that I make. I feed it articles that I write, so it writes in my same tone. And so AI learns all about you and how to mimic you if you want it to. So if you get an email from somebody these days, you don't really know if it's a real email, or if it's from Genie, or if it's from another AI system, because they're often used. But AI is really taking all this data from different places and then filtering it through and making decisions from it. And the decisions are pretty good already. They're going to get better and better. And so I'm going to talk about a little bit about that, and then we'll talk about what that looks like for respiratory care. So this is really what's happening with all these large language models. Everybody in the marketplace in technology is now in AI. There's not a company out there that's not focused on AI. And the amount of money that's going into AI, I mean, you can't find AI programmers. We tried last year. We were working on trying to find one, and these guys are making like $1 million a year because there's such a need for them right now. You can't hire an AI expert coming out of Carnegie Mellon or coming out of one of these big universities for, unless you hire them as a student, you're going to be paying big money for them because there's such a need and there's not enough. So if you're looking to do something on the side, AI is probably the place to go. So how does ChatGPT work? Well, here's a real simple version. I just said, write me a song about an awesome respiratory therapist. And here's the song. Anybody want to sing this? I mean, if you got a little rhythm, you can come up here and try. Somebody, Jimbo, you're the guy. No? Okay. Can you guys read that back there? So, I just said, write me a song about a respiratory therapist. And it's a pretty cool song, right? If I had if I could stay in tune, I'd sing it to you. But it is, if I then asked this question, I didn't put this on there, give me the chords to play it, and it would give me the chords to play it. And then if I say, hey, I don't really like this part, make it about a home care respiratory therapist, it would change it to that. Right? So it's very intelligent. Some of you guys that have ChatGPT already know this, but if you don't, you never really play with it much. It's pretty cool what you can do. Now here's how it comes into patient care. Were you taking a picture? I'll go back for you. So what's it mean for patient care? Well, in the future, and really now, you're going to start seeing charting systems use AI. Our software platform, we've got some AI built into it. And so here's a question that I asked. Write me a note from a respiratory therapist to a pulmonologist letting them know that their patient, Ms. Jones, might have bronchiectasis and make some diagnosis recommendations. Now, I didn't give it any information about what to make, but check out what it did. Can you read that? No? All right. Dear pulmonologist, I hope this note finds you well. As I'm writing to discuss the case of Ms. Jones, a 62-year-old female under my care. Ms. Jones presented with a chronic cough, copious sputum production. Like, where'd that come from? I didn't say that. But because I said bronchiectasis, it already pulled what the symptoms would have been, and it put it in the note because that's how smart AI is, right? But also a little scary. And recurring respiratory infections. Upon further evaluation, her chest CT reveals bronchiectasis, like changes. Who said she had a CT? I didn't say that. But I did say she was diagnosed, which means she probably had to have a CT, which means that it made some pretty big assumptions about what to write. But this is crazy, right? And so then it goes on to say, given her clinical presentation and imaging finding, I suspect Ms. Jones may have bronchiectasis. This condition could explain her symptoms and recurring infections. With further investigation, including sputum cultures, pulmonary function testing, would be beneficial to confirm the diagnosis. I would recommend starting Ms. Jones on appropriate antibiotic therapy based on sputum culture results, as well as initiating airway clearance techniques to help manage her symptoms. That's pretty crazy, right? But that's what AI can already do. And this is not a healthcare AI. This is just ChatGPT. So think about if you started to teach it about a patient and teach it more about healthcare, then it would get even smarter and smarter. And that's really called machine learning. So artificial intelligence is driven by a machine learning engine. And machine learning simply means that you teach the machine, the brain, more and more about patients. So the more data that you feed to the artificial intelligence, the smarter it gets. And then you start to teach it in different ways, so it picks up on how does it evolve into a much more intelligent being. So it's kind of scary to think about, right? Because like I said, there were some movies about this, and they usually didn't end very well. But it's deep learning, machine learning is really the science behind how do you feed information to AI to make it smarter. And when it gets smarter, it can make better decisions, and it can make its own decisions. And so it's, again, a little bit scary. But how does that work? So right now, where do you see machine learning and AI? It's every bit of data that you process, whether you run your credit card, where you travel to, you're being tracked in everything you do, right? I'm not a conspiracy theorist, so I'm not saying that we should wear some some hats with aluminum foil or something. But what I'm saying is that in Livingston, the little town we live in, we get all the data on when we have an event, right? So we have an event like Halloween we had a couple weeks ago. We know who came to the event, where they came from based on their cell phone data. We know how much money comes into every single town in the country based on credit card transactions, debit card transactions. So everything that you do is being tracked by the data is, and then it's being fed into machine learning, and it's being fed into artificial intelligence. And so every call you make, all those things, even if they don't know what you're saying or what you're doing, all those things are being tracked, and they're using it to make decisions, right? In the little town we're in, one of the things that they did recently was they said, hey, there's millions of dollars going out of this town to shoe stores in the surrounding areas. We need a shoe store. So every decision being made by a town, by these big tech companies is all being made off of data these days. It's not assumptions anymore. And so the amount of data that's coming in is powerful, but also is a little bit scary. But it can be used to make really interesting decisions, right? And to do things like prevent fraud and prevent, I mean, those little texts you get up from your banks are probably using AI, unless you're using a little country bank like the one we use in Livingston. They can't spell AI, I don't think. But so what is machine learning? It's a couple things. One is that when you feed data to AI, then it does something called machine learning. And that machine learning is, there's a couple different styles. There's supervised, which is when you literally sit there. So in healthcare AI, what's happening is that healthcare providers are feeding information into the machine, right? And then telling it, hey, this is what you do with this patient, right? So you got an ALS patient, and here's the symptoms, and here's how they present. Then you literally would go in and say, well, in this case, you would do X, Y, and Z. And then it would learn that. And then the more you teach it that same thing, the more it would learn. And so it would keep that memory, and then it would continue to the next phase, right? And then after a while, it starts to make its own decisions, which is unsupervised, where it says, hey, logically, this makes sense. So you see in the picture here, like, this is a circle, this is a square. So it starts to understand things unsupervised, right? And then reinforcement, whereas it starts to understand that you told me something and I figured something out, and then now I've reinforced it because I figured out that, yes, this is a circle and it fits in this circle hole, right? So that's really how machine learning works. And so the more information, the more data that comes in, and then the more that we interact with the machine, the smarter it gets. Now, how's it being used in healthcare today? It's actually being used quite a bit. If you look up studies around AI, there is a ton of information around how it's being used in healthcare. And here's the interesting thing is that in most of these areas that it's being used, it's actually becoming as smart as a human. So most of the studies are looking at, x-rays and things like that. Can it do as good as a physician at diagnosing something? And the answer is usually it's almost as good or as good these days, but soon it's going to be better. And so, again, that's a little scary, right? But think about medication errors that happen. Think about, cancer research, all these things on drug development, all those things. AI could make us so much better and more efficient in some of these areas and make it where we don't make mistakes a lot of times. And so the place that it's already being used is enormous, but it's going to be more and more. So this is a study that looked at Northwestern medicine, and what it looked at was using AI to interpret x-rays. Could it get as good as a physician? And what it said is that it basically rivals a radiologist doing an interpretation. But now think about this. Now I believe, you guys may think I'm crazy, I believe my kids will probably live in a time where it'll be illegal to drive a car. Because self-driving cars right now are kind of scary. But once they get better and better, eventually it'll be too dangerous for people to drive because there's no wrecks in self-driving cars. And so I believe that we live in an era where we're going to see a lot of evolution around AI and technology, and it'll probably become illegal to drive at some point. It'll probably become to the point where a physician can't do as good at interpreting something like this because of human error as a machine can. And so when we get to that point, think about if a machine has interpreted 1 billion chest x-rays and it knows every little detail in that chest x-ray, then eventually it's going to get to the point where it's smarter than the human eye could ever be. Think about that. Kind of crazy to think about, but it's true. And so as this evolves, we're going to see more and more AI. Now, Enzo Data is a company that was here yesterday who had a booth in there. They've done this for sleep medicine. And so what they've tried to figure out is how could they use AI in sleep medicine to really cut down the amount of time that it takes to interpret a sleep study. And the other thing that it does is it AI-powered starts to create the ranking, right? So if you're looking at 1,000 patients and you got to go through all the charts and look at them, then you got to dig through one after another and find the information, right? Well, so what this does is really force ranks or use AI to figure out who are the problem patients and put them at the front of the line so you know who to focus on, so you're not spending half your time going through charts that you don't really need to go through, right? So AI is really changing sleep medicine a lot, and we're seeing that more and more. I didn't put it in the presentation, but another one is Genie, which is up in Pittsburgh, and Kim was just talking about that. She uses it, and it's an AI-powered sleep coach. And so basically what happens is it engages with a home CPAP patient through AI, and then when needed, it pulls in a human. And so it will try to reach a patient through text message, through calls, and it can actually talk to you. And when you talk to it, talks, right? When you talk to these AIs, a lot of times you don't really know it's AI. It doesn't sound like a robot anymore, and it evolves, and you can make it talk different ways. And so Genie is a really cool way that sleep medicine is kind of evolving. And so here's the thing: is that in sleep medicine, with that product, you could manage 1,000 home CPAP patients versus 100, right? What's your number, Kim? Not to put you on the spot. 500? So did it help you as far as how many more you could manage using Genie versus? Wow. So our compliance wasn't real good with the AI involved.
I don't want to give you what that number was.
Yeah, that's fine. It's a little bit less than 78. But with Genie involved, with AI involved, it's now at 78% compliance. And the amount of RT time or clinician time that goes into that is less. And here's the deal, is that when you hear that, you think, well, we don't want less RT time, right? But here's the thing, is that if we don't use technology to supplement what we do, there's not enough payment out there. I don't know if you guys know this, but respiratory therapists cost a lot more than they used to, right? And in home care, we didn't get an increase in pay. In the nursing home, we didn't get an increase in pay. And so now the fact that we have to spend so much more to provide care, but we don't get to call Medicare and say, hey, I'm paying a little bit more for staffing, could you do me a favor and increase my price? It doesn't work that way, right? And so in the world that we live in, we got to figure out how to be the MacGyvers and embrace this kind of technology. Because if we don't, it could replace us in some cases, but also could give us the opportunity to do better care and to do what we were trained to do, right? And so if we can figure out how to use AI to supplement, like Genie, where you can manage more patients and you're not focused on the patients who aren't problem patients, but you're really focused on the patients who are the problem patients, right? So it's going to identify and force rank and figure out who do I need to focus on. And this is going to happen in the hospital too. If you look at these numbers on sleep studies and home sleep studies, it basically saved 31 minutes on a PSG using AI over not using AI. So you could see the difference there, 62% time savings by using AI. Home sleep testing, 20 minutes per HST. So that's 68% savings in expense. So think about that. I mean, if you can use data to make yourself more efficient, can manage more patients, then it allows us to provide better care. Now, the next phase that everybody's working on right now behind the scenes is AI-powered ventilators. And so this will be what we see very soon. And here's the thing, if you think about it, right, if we're at the bedside managing a patient and we have to go in and figure out all the measurements and figure out can we adjust settings and figure out, do they pass trials? Well, that's just data that we're figuring out so we can make a decision. That could be done by a ventilator, and that's what a lot of people are working on right now, is how we can have auto-adjusting ventilators. We already have it in some cases, in home care especially, auto-adjusting settings, but it's going to get to the point where it can be for weaning too. And there's already studies happening, there's already devices out there. There's actually a device I'll show you in a second. I think I put it in here, but you put it in line with the ventilator and you feed it information, and then it helps you make decisions about when to wean. And that may be offensive to some of you guys, right? Because is AI going to take our jobs? That's what everybody's wondering in the world. And I don't think it's going to take our jobs, but what I do believe is that we have to evolve with it. Because if we don't evolve with it and we fight against it and we don't change, then we're going to be in a position where it could, right? But we got to figure out how to embrace technology. The MacGyver of old is figure out how to put all the pieces together to make a device to ventilate somebody. The MacGyver of new is figure out how to use technology and software and data to make better decisions about hospitalizations and about how we manage care and about how we ventilate patients and how we wean patients. And so it's really the change in the times. I believe we're not going to see a lot more advancements in boxes, right, in technologies and ventilators. We're going to see advancements in how we use data to make decisions. And that's really what we're seeing today, and that's where AI comes in. So a couple things on ventilation. If you think about what it could do, predictive analytics around when to put somebody on a ventilator. They did a lot of studies during COVID to try to predict who was going to need ventilation and when they needed ventilation, and they used a lot of AI to do that. And it was necessary, right? We didn't have enough ventilators, and so we're trying to figure out what to do. So they're trying to predict where the hotspot's going to be and how many ventilators will we need, and when somebody gets diagnosed, what are they going to need ventilation or not? And so a lot of AI came in during that time. And then automated decision making ventilator changes without somebody being involved. And that's kind of scary for us. It really is. But at some point, the more data gets fed into the machine, the smarter it's going to get. And it'll get to the point where it could wean people faster than humans can. And that's just a fact of where we're going. And like it or not, it's going to happen in the next 10 years. And so, anybody scared by that? A little bit? Do what? Pulmonologist should be? But if you had a family member who on a ventilator, and you could wean them 2 days faster and avoid infections 50% less likely to get infected, then we would want that, right? But for job security, it's like, hey, what's this going to do to our jobs? And so I get it. But we got to figure out how to evolve with the times and not fight against the times. And then cost savings. A lot of the data is indicating that we're going to reduce infections. We're going to reduce all kinds of things, hospital-acquired infections, those types of things, using AI and using data. And we're already seeing that today. This was the study I was just talking about, where it looked at predicting the need for ventilators. So here's a couple things that Encore, one of the things that we're doing is we're using some AI in the background to help make decisions for patients. And so just, you guys know Encore for the conference, but the other thing that we do is we manage a lot of COPD patients and provide software and a platform to do that in. And some of the things that we've done, so we had this vision 10 years ago that if we had a program where respiratory therapists could have a tool to manage patients outside the hospital, then we could have better care and better outcomes and better results. And so back then it was never about AI, but it's kind of evolved into where could AI fit into that. And so at this point we've managed 140,000 patients across the United States partnering with DMEs, and we've got lots of data, probably more data than almost anybody when it comes to the home, right? And the data is not just device data. So if you talk to manufacturers, they have a lot of device data about what's the box doing, what's the compliance, those types of things. But we have that data plus how does somebody feel. And how does somebody feel oftentimes in home care is whether or not they're going to go back to the hospital or not, right? If your SATs are 85 but you feel fine, you're probably not going to the hospital in the home, right? Because you don't know your SATs are 85. But if your SATs are 95 and you feel like crap, you're probably going to go to the hospital. And so how somebody feels in the home is more predictive. And the last speaker was talking about CAT assessments and COPD assessment tests and some of those predictive type things that tell a story, a trend over time. And so a lot of that is the ways we can make decisions with technology, with software, with AI. And so one of the things that we've proven is that if you put respiratory therapists managing the care of patients outside the hospital, you're going to reduce hospitalizations and you're going to have better care. And we've proven this unequivocally. So using DMEs or partnering with DMEs or partnering with respiratory therapists in the home through respiratory companies, we have seen over 100,000 plus patients that if you follow a playbook of managing the patient care and you do it effectively and efficiently, you reduce hospitalizations by 60% or more, right? And we've never had this kind of data outside the hospital. Generally what happens is in home care, most of the home care companies are businesses, right? And so don't want to share their secret sauce, and so we don't publish a lot when we get to home care. When we get outside the walls of the hospital, in hospital and academia, publishing is part of what they do. But when you get outside the walls of the hospital, you don't see a lot of publications, right? You don't see a lot of this type of data. But what we've seen is that across the board on 100,000 plus patients, if you have a respiratory therapist involved in the management of a patient, not just of the device, then we reduce hospitalizations by 60% or more. We just published a study, I didn't put it in here, but at ATS, we had 3 abstracts this year, and one of them was on 17,000 patients on non-invasive ventilation, and we avoided 34,000 hospitalizations using a respiratory therapist to manage beyond just the box, but managing the whole patient, right? And so the amount of data now that we have coming out of the home, we had another one that was 32,000 oxygen patients. And what we were trying to prove was that if a respiratory therapist was involved in the care, not in the home, but just over the phone in making phone calls, doing assessments and managing their care, that we could reduce utilization. And we reduced hospitalizations by 61% by having a respiratory therapist make a 10 to 15 minute call every month to a patient and try to solve problems for them. So think about that for a second. 61% reduction on an oxygen population, just by making some phone calls and trying to figure out systematically how do we solve problems, identify gaps in care, get them on the right therapy, get them on the right medication, and then give feedback to their physician, right? So having a respiratory therapist involved, that's been our strategy for the last 10 years, is how do we prove out that respiratory therapists are what makes a difference. And any manufacturers in the room, don't hate me after I say this, but oftentimes nobody's done research except for the manufacturers. And so a lot of times the manufacturers will say, hey, the improvement in reduction in hospitalizations or the improvement in care is based on, our device. But I would challenge that and say, well, a lot of it's based on the respiratory therapist that comes with that device, right? But we don't have any of that data. And so it's easy to take the credit for that, to say, if you put somebody on this device, you get this result. But in the background in the home, you've got a respiratory therapist involved in the care with that device who's making a lot of the difference, right? But we've never taken credit for it. And so what we've seen in our profession over the years is that a decrease in reimbursement more and more and more, because we don't have any way to prove that the respiratory therapist is the one that made the biggest difference, right? We're treating the symptom with the device, and the devices work, and obviously it's the bread and butter of what we do, but the respiratory therapist, I would say, makes as much of a difference or is as or more important than the device that we provide, right? So AI is really a big part of hospitalization reduction these days, and there's a ton of companies out there that are for ACOs or for payers that are analyzing data and trying to figure out how to make better decisions. What could we have done differently? What medications we're missing? What therapies we're missing? And so we're going to see an evolution in that in a big way over the next couple of years. But that's already out there. One of the other things that we did this year at ATS was we looked at a study that said, hey, if we used AI, how could we start to predict what happens in the home? And this you probably can't see, but I'll explain it to you. The 3 lines on here. So that line, the blue line, whatever color that one is. What's that one, Jason? Green, I'm colorblind. So, and then the bottom line here, orange line. Yeah, thank you. So if you look at those 3 lines, essentially what we were looking at was, what was the reduction in cost of care by putting devices in the home and then putting device and a respiratory therapist using a disease management program. And so we found some pretty staggering results, and we published this at American Thoracic Society this year. And those results were basically, I've got them on the next screen here, that if you had a respiratory therapist using a software engine that was driven by AI technology, what happens is that you had a $108 million reduction in care and savings or in utilization over every 1,000 patients over a 5-year period. So think about that for a second. A respiratory therapist having a strategy in the home could save $108 million over a 5-year period for every 1,000 patients. Now think about how much money we could save if you put us on every COPD patient in the world. But the problem is, there's no way to get paid for that service, right? The problem is that we have not done the work as a profession to figure out how do we get respiratory therapists paid for and not just devices paid for. And there's all kinds of talk out there in the home care space. It's always about how do we get this device paid for, or that device paid for, how do we get our service paid for that we provide. We should be talking about how do we get respiratory therapy paid for. And that conversation has not gone very far. And really, to be honest, if you think about even our professional organization, it's 90% hospital. And so we've not been focused on what is most important, because we have this silver tsunami coming, which is the baby boomers we can't even provide enough care in the hospital over the next 10 years to care for all these patients. It has to go outside the hospital. And the problem is that as respiratory therapists, we don't have a big place outside the hospital. And it's really, I would say, it's our fault, right? We haven't done the work to do that. And so here's the other thing that we found was over a 5-year period, a DME providing ventilator management saved about 10%, so 25 million in savings. So if you looked at that same study for populations who were on non-invasive ventilation, then it was about a 10% reduction with just the device, but then you add in the respiratory therapist and a program on top of that, and you get $108 million savings. So pretty staggering results, but it just shows the value of what we could provide if we had a strategy and a systematic approach and a way to get paid for what we do, right? This is the other thing that we did, was we built this tool where we could walk into any payer and essentially they could give us their data and tell us how much they're spending on COPD. We could put it in this little tool that we built through AI, and essentially we could tell that payer how much money we could save them by putting a respiratory therapist in the home managing their care. And so if you say, I'm spending $400 million on COPD, we put those numbers in, put the cost of each admission in, and then we run the analysis and say, okay, if you put a respiratory therapist in the home, then what you're going to see is a 60% reduction in your spending. So we can literally tell a payer how much money they can put back in their pocket by using a respiratory therapist in the home. Now, getting payers to listen to you, that's the challenge, right? This is some data from Florida, which is pretty staggering data. In Florida alone, and I use Florida just because we had a data sharing arrangement with Medicaid in Florida, and so we have really good data in Florida. And what we saw was they did a study, and they said that the biggest problem was they didn't have effective care extensions in the home. They didn't have programs, for COPD. They didn't have anybody managing the care in a care management or a complex care management kind of model in the home. And so these were the problems that they put out in a study. And we looked at their data, and what we found was that they're spending just their MCOs alone $420 million on COPD as a primary diagnosis. This is just Medicaid alone in the state of Florida. It's about $550 million if you look at the fee-for-service as well. So $500+ million a year in Florida being spent on COPD. And they did a study and said, we got this huge problem, and the number one reason, if you go back, let me go back a slide, the number one reason for preventable hospitalizations was COPD. And they don't have a solution for it. But that's not just Florida, that's the entire country, right? And here's the thing is that oftentimes in the hospital we're trying to create solutions for after patients go home when the hospital's not really set up to do that, right? And so you see all these programs where we have COPD navigators and we have people in the hospital that are trying to do something to avoid readmissions, and that's a great thing, and hospitals should be doing some of that, but if they don't have that connection after they leave, then we're not going to have a successful transition no matter what, right? Or it's only going to last for 30 days, then they're going to come back after that. And so it just can't be done in acute care. It's got to be a team effort across the board in respiratory care to say, how do we manage these patients' transitions, and how do we manage their care all the way through? So this is essentially, if you put that model I showed you a minute ago, if you put that on top of Florida's data, this is what would happen. So the first line where it says 1,016 patients there, right here. And then the next one is $6.4 million, so those are dollars in the second graph. And then the blue one, 15.5 million. So essentially what that is that's 1,016 patients. If you manage them with respiratory therapists, it would cost you $6.4 million. It would cost Medicaid $6.4 million. But the amount that they would save is $15 million. So that's pretty staggering. That's just saying if you paid for a respiratory therapist based on our data, based on our model, based on all the data that we've got, essentially you're going to save that kind of money. And as you go up, you go to 3,000 patients, it costs $18.9 million to manage 3,000 patients using a respiratory therapist in the home, but the savings is 45, almost 46 million. And if you go all the way up to 12,000 patients, just in the state of Florida, which is their high-risk, high-cost patients on that data I just showed you, it would cost $75 million to pay for a respiratory therapist in the home in the state of Florida, just for Medicaid, but it'd be $183 million in savings per year. Think about that for a second. We would pay for ourselves, and we'd put money back. That essentially says that every dollar they spent on a respiratory therapist, they'd put $1 and some change back in their pocket. So this is what we're starting to figure out, starting to know, but now we got to figure out what do we do about it, and how do we start to get paid, and how do we start to go beyond the box of just managing equipment outside the hospital and really managing the whole patient. So the way that I believe that's going to happen is that we're going to see a drastic change in technology. We're going to see AI and data. I mean, like I said, there's software companies and data companies popping up all over the place. And some of it's going to stick and some of it's not. Genie's a good example. It's somebody that we know who started that company with an idea, and now it's taken off and they're doing a great job with managing PAP patients. We're going to see more and more of that. We're going to see more of the care. I mean, some of the things that we do in the home is we have telerespiratory services, which is where we have respiratory therapists in the home that manage patients all over the country. And so essentially we're managing ventilator patients, oxygen patients, patients on airway clearance, sometimes PAPs, but mainly respiratory patients. And essentially what's happening is that we can do as much and sometimes more through telemedicine as you could do in the home. And when I say more, it's because in the DME world or in home care, in post-acute care, oftentimes there's just not enough money that's being paid for that device to go send a therapist out every month or every 2 or 3 months, right? But with telemedicine, we can do it at a very low cost and very effectively and efficiently. And so one of the things that we do today, we probably have 45,000 patients who have been managed through telerespiratory care all over the United States, where we are managing their care with an RT sitting in their home, calling the patient, either doing a telemedicine call or sometimes just a phone call. Like I said with the oxygen patients, we just do a phone call and we've made that kind of an impact on utilization. On ventilator patients and airway clearance patients, we're even doing some remote setups on some of those patients, and what we found is that sometimes the data, the compliance, the engagement, the pickup rates, all those things are better with remote setups and the continuity of care of having the same therapist managing your care and engaging with you more through telemedicine than having somebody live. And so we would think that if you did telemedicine that we wouldn't have as good of a compliance rate, we wouldn't have as good of we'd have a big pickup rate, but that's really not the case. We've seen it be either consistent or even better sometimes doing remote care, even remote setups on things like high frequency chest wall oscillation. We've had better results. And so think about that for a second. Now we could either embrace that, and some of us do, right? Because like, I want to work from home. Anybody want to work from home? Some people do. I don't, but some people do, right? We could either embrace that, or we could say, well, that's not right. We shouldn't do it, right? But the data says that we can have better results. We can have as good or better results using technology, using telemedicine, managing patients remotely. And here's the deal, is that you just can't get to every patient's home, right? When they're hundreds of miles away, it's impossible to send a respiratory therapist out on an oxygen patient anymore. There's just not enough reimbursement, or on a nebulizer patient. But we could have respiratory therapists involved in their care remotely. Even if it's 10 or 15 minutes, we've proven that with that kind of engagement, we have better outcomes, better results, right? So here's what I think is going to happen. I think that we're going to see care start to shift outside the walls of the hospital. We're going to see a lot more technology. We're already seeing that. A lot more data. I mean, the days of data is here, and there's so much data out there to make decisions with. But we're also going to see where our respiratory therapists will come into play, because the more data we have, the more we're going to be able to prove that we should be paying for respiratory therapists, we should be paying for these services, and that there's a model outside of equipment to be able to get paid. And so what we see is, and this is in a perfect world, that you have this combination model of RTs in the home. You've got care coordination going on, especially when we're talking about working with a payer, with a health plan. This is what it looks like, right? It's a lot of case management, care coordination. It's RTs in the home. It's telemedicine RTs, and then it's using technology to make decisions, using software to make decisions, and those decisions are going to get better and better and better. And the thing about it is that, 10 years ago, if you needed an improvement in software, it would take you a long time to get that. Well, nowadays, software, the way it works, is all cloud-based, right? So it's constantly evolving every single day. It evolves. And so if you looked at a software 2 years ago and didn't like it, you might want to look at it again, because it's probably a totally different software now, right? Things evolve quickly in this day of technology. And so I believe there's going to be lots of automation, kind of like Jeannie that I was talking about, the AI bot that manages sleep patients. A lot of automation will start to happen where we can have an AI respiratory therapist, right, who could make calls and do the lower level conversations, and then if it escalates to needing a human involved, then it escalates to that. And that's what's happening now today. And so we're going to see more and more of that. And I think hospitals will start to adopt that. I mean, think about hospitals don't have budgets to manage patients when they leave, but there's some hospitals now that are doing things like automated calls and are doing things like follow-up assessments by text message. Those types of things have been happening for 10 years. But they're going to evolve more and more to a point where hospitals can manage patients using technology a lot more effectively and efficiently, and so can home care companies. And then the other thing that's really evolved is all this vitality, what we call vitality sensors. And so, telemedicine or RPM is a big thing right now, remote patient monitoring, and it's kind of blown up on the scene. And with remote patient monitoring, it used to be pulse oxes or scales that you put on. And if we're going to be honest, we're talking about a COPD patient, pulse ox and a scale and a blood pressure cuff really doesn't tell much of a story, right? But there's an evolution happening in RPM, and so there's all these new products out there that can track steps and respiratory rate, things like that are pretty effective for a COPD population. Or sleeping patterns. One of the things that we're doing a pilot right now with a company that just puts a strap around the patient's bed, their mattress, and looks at heart rate and respiratory rate while sleeping. But there's some really strong data that says changes in heart rate and respiratory rate overnight while you're sleeping are predictive up to a week ahead of time of an oncoming exacerbation. Now, a lot of times I wouldn't have thought that, but that's where data is starting to tell a different story. I mean, respiratory rate, we would think the day before, right? But not a week before. But what we're seeing in some of this data is just tracking resting respiratory rate and heart rate could tell a story about what's about to happen with the patient. So RPM is really evolving. There's another product that's really cool. It's a respiratory product. You take this little sticker, and it goes inside of your underwear. Sounds crazy, right? So you put it inside of all the patients' underwear. You get like 10 of them. Put it in all their underwear if they wear underwear. Statistic you don't want to know, but I'm going to tell you anyway, is I was talking to that company, and they're like, it turns out 10% of COPD patients don't wear underwear. It's like, why'd you tell me that? So now I'm going to share all that with you. But it goes inside their underwear, and it tracks steps and respiratory rate, heart rate, and now it's even tracking pulse oximetry from inside their underwear. Doesn't that sound crazy? But that's where we're at today. And so if you think about these passive ways to monitor patients, the passive monitoring is the future. And that is, if I knew how many steps you took every single day, then I would know if you're up moving around. And if you're not up moving around, then that means you're probably not feeling so good, right? I mean, we've seen things where we look at patterns of how much people move around their home, or how much they make coffee, or they use their TV. So there's all kinds of evolution of how can we look at a patient's patterns and figure out has something changed. And we're going to see that more and more. And I think that's a big part of how we manage patients in the future, is kind of incorporating some of those things. There's now rings you can wear that do pulse oximetry, heart rate, step, all those things. There's patches you can wear. There's all kinds of stuff. And we're going to see more and more of that. And so how do we incorporate all of those things together, having respiratory therapists, telemedicine, having technology, devices that the patient's on, and their data, having RPM, all of that together to tell a story of how do we really effectively and efficiently manage a patient. And so the closing thought, change before you have to. As a profession, oftentimes we're stubborn. Anybody stubborn in here? We're stubborn sometimes, right? We're human. But we're stubborn, and we don't want to adopt new technologies, and we all get that way. I mean, I remember early in my career, I was all about every new technology that came out, and then at some point in your career, you get to the point where it's like, well, I just don't want to think about something new, right? I've already got all this stuff that works. Now there's 18 new products that I got to go over here and see and try to figure out how to incorporate and write a new policy around and all those things, right? And so we get to that point where we just get a little bit stubborn, especially the longer we've been doing it. But I challenge us is that technology is the future, AI is the future, software is the future. Things are evolving, and if we don't evolve with them, we will get left behind. And so not getting left behind means we got to figure out how to embrace these things, how to include. I mean, think about what you could do with all this stuff that I just talked about to manage a patient in the home and do it effectively and efficiently, to manage a patient who leaves the hospital and do it effectively and efficiently. It's a game changer, right? We just got to figure out how to be the MacGyvers and how to bring it all together and how to make products and make services and make ways to use respiratory therapists to evolve our profession. All right, thank you guys.